Good evening and welcome to Doctors on Call. I'm Dr. Paula Termuhlen, Regional Campus Dean at the University of Minnesota Medical School, Duluth Campus, and I am your host for our program tonight on upper GI problems. Our panelists this evening include Dr. Jon Reich, a gastroenterologist with Essentia Health, Dr. Stephen Vopat, a general surgeon with the Community Memorial Hospital in Cloquet, and Dr. Derek Williams, a general surgeon with the Fairview Mesaba Clinic-Hibbing. Our medical student volunteers answering the phones tonight are Jake Krogstad of Eyota, Minnesota, Chelsea Petrick of Elk River, and Peyton Schultz of Hamburg, Minnesota. As always, the success of this program depends on our viewers, so please call in your questions on heartburn, indigestion, ulcers, gallstones, and abdominal pain, and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of the screen. And now, on to tonight's program. So Dr. Reich, we were talking earlier about a lot of patients who happen to be on acid-reducing medications, known as PPIs. There's been a few things in the news lately about some of the possible complications of those medications. Can you talk to us a little bit about that?
Yeah, I'd be happy to. I get this question every day at work. Proton pump inhibitors are a class of medications that are very potent at blocking acid release in the stomach, and they're probably the best medicine we have at controlling things like heartburn and symptoms of stomach ulcers. Mm-hmm. And some of the side effects potentially of proton pump inhibitors are fairly mild and have been fairly well proven to be present in patients. And these include things like low magnesium or B12 levels or small intestinal bacterial overgrowth, which these problems generally can be followed and those electrolytes can be replaced. Some of the other side effects that we get asked about, things like dementia, things like chronic kidney disease, have been in the news over the last few years. It's been really difficult to tease out if those are real side effects or not. Tens of thousands of patients have been looked at with these, and some studies say yes, some say no. And so what it really comes down to with the proton pump inhibitors, we really try to individualize it for our patients, and we say, in my opinion, some of the more serious potential side effects are probably overblown, but we always take it into consideration.
Sure.
And if the medicines are helping you with problems that you really need to take them for, probably the benefit outweighs the risks of those medications.
That's great. Well, and we know that acid can cause ulcers, but I was thinking, Dr. Vopat, could you talk to us a little bit about some of the other causes of ulcers?
Sure. I guess one of the big ones is a bacteria called Helicobacter pylori, which is something that we didn't really know about until probably the 90s or so. People would treat ulcers and then they would reoccur, and we couldn't figure it out. And then they identified these bacteria. So if we identify those, and there's several ways to test for them. You can test with a blood test to see if you've ever been exposed to them, you've developed antibodies. There's a breath test that detects a byproduct of their metabolism. Or when we do upper endoscopies, we can biopsy the stomach lining to test for them. And so if you identify their presence in the stomach and you've got an ulcer, in addition to acid reduction therapy, you'll often treat with antibiotics as well. And it's generally like a 10 to 14 day course of a couple of different antibiotics, because these are tough little bugs. They can live in stomach acid, and so it just a standard course of a Z-Pak or something isn't going to get rid of them. But I guess that's probably and then other causes of ulcers would be things that break down the protective mucus lining of the stomach. So common drugs like the non-steroidal anti-inflammatory drugs, or NSAIDs, that people use commonly for arthritis. As a general rule, what our joints like, our stomach does not, and it tends to break down the mucus, and then the acid can attack the lining a bit more.
Fair enough. Well, and so, Dr. Williams, we were talking earlier, we know that all three of you do the upper endoscopy, upper GI testing with the scopes, where people examine the lining of the esophagus and the other parts of the upper GI tract. So if somebody's maybe been treated for ulcers, at what point do you go ahead and examine them with a scope?
Usually, if the symptoms are not being controlled with the medicine, then I usually will go in with the scope. I'll also do it for somebody who's been on it for a long period of time, because I want to take the biopsies to see if there's been changes where the esophagus and the stomach meets, something called Barrett's esophagus, which is something a long time ago thought to be a precursor to the cancer. Well, that's now a little bit overstated, but Barrett's esophagus with dysplasia is a true risk for cancer, and I don't want to miss that. So those are some of the reasons why I would take somebody to do what we call an EGD, or what I like saying, esophagogastroduodenoscopy.
Ooh, that rolls off the tongue.
It's fun to say, but it's not fun to write.
True.
Right.
Well, it's interesting that Gary from Grand Rapids was our first question tonight, asking about Barrett's esophagus and really wanting to know what causes it.
Well, I'm sorry.
Yeah.
Yeah.
Well, so Barrett's esophagus is a change in the lining of the esophagus tube. That's the muscle that connects your mouth to your stomach, delivers food from mouth to stomach. And when you have reflux of acid, and we think probably there's a component of bile actually that may contribute to Barrett's esophagus as well. Bile comes out of the liver and the gallbladder, and sometimes it can actually go backwards a little bit into your stomach. But really it's reflux. Makes the esophagus essentially change, almost adapt to the conditions to make it look and appear more like stomach lining. The problem is that the esophagus is not supposed to look more like the stomach, and it can, in some folks, be a precancerous condition for esophagus cancer, and there's a lot of things that go into that. How much of the esophagus is affected, whether it's just a half an inch or whether it's much more than that is a predictor. And then when we biopsy at the time of the esophagogastroduodenoscopy,
Very nice.
there can be excessive mutations called dysplasia. So there's a lot that goes into that.
Very good. Well, so we have another question on the topic of reflux tonight from Lynn. And Lynn had her gallbladder removed about 1.5 years ago, but seems to have more reflux now. Is that something that's commonly seen?
We see it occasionally, and I think my explanation for it is both diseases occur commonly. A lot of people get reflux, and so it may be coincidental that they're getting more, or that they're noticing more reflux after their gallbladder is out. I don't know if there's a particular association. I guess I'll defer to my colleagues if any of you.
Well, I think it becomes a little difficult because diseases of the stomach, reflux, and diseases of the gallbladder can mimic each other. And sometimes why we think we're taking out the gallbladder for biliary colic is actually more reflux. So we took out the gallbladder, they healed from that, and they still have their reflux.
Suddenly they don't have their gallbladder pain anymore, and they're noticing the reflux a bit more too sometimes, I think.
Oh, fair enough. Well, so while we're on the topic of indigestion, we have a question about, does apple cider vinegar, which is a very popular drink right now, sort of a health drink, if you will, does it relieve stomach indigestion?
Well, I also get asked that question quite frequently. And in some cases, it doesn't always make a lot of sense that would be the case, because apple cider vinegar is an acidic fluid, and your stomach makes acid. And if you add to that, could you be creating more acid trouble? But one of the things that it may do is help in folks who have maybe excess bacteria, maybe folks who are on acid blocking medicines to help digest food a bit better, to decrease gas, to help with those things. And for lack of better data or research, I hear a lot of people tell me that they take apple cider vinegar in small amounts and it helps their indigestion, and sometimes we don't know exactly the underlying reason for that. But I would caution folks to mix it with some water if they're going to use a little bit of apple cider vinegar, because sometimes I've seen people with their teeth having eroded because of the acidity of the vinegar. So
we don't want to cause a new problem,
right?
All right. Well, so we have a question from Two Harbors. What causes severe gas in the stomach?
A lot of times it just has to do with what we eat. So there are certain gas-causing foods, the classic being beans and onions and things like that, that have a lot of fiber that is less well digested. And so the bacteria in the gut tend to digest it and produce gas as a byproduct. I guess other things that would come to mind would be if for some reason the stomach and the intestinal tract isn't propelling things through like it ought to. Diabetics sometimes get a condition called gastroparesis, where the stomach just doesn't empty as well. So the food might stay in there and get a little more stagnant and again be metabolized by the bacteria, which produces gas as part of that process.
Well, and you brought up one other thing that I've heard a bit about is where people are reluctant sometimes to increase the fiber in their diet because it sort of starts in the stomach and works its way down, but it can make people feel a little uncomfortable. Some people have an increase in gas, I think, both in the stomach and then in other parts of the GI tract.
Oftentimes if I recommend a fiber supplement to somebody for lower GI problems, constipation, I'll advise them to maybe try starting with half the dose on the bottle at first for the first week or two and then work up so they don't quit it altogether because they suddenly get the extra fiber and the extra gas.
So we have one question, just going back to our topic, we were talking a little bit about Barrett's esophagus, and there was a question about what's the treatment for Barrett's esophagus? We talked a little bit about biopsying it, identifying it, maybe some of the causes. Do we have any treatments for Barrett's? I know a major one that we don't do as frequently anymore, but.
Well, normally we would treat it medically with the PPI, but I believe our colleagues in gastroenterology, they have some more advanced techniques with their endoscopies, cryotherapy, and you would probably know more.
Yeah.
Probably the most used technique, which is very, very successful, is what's called radiofrequency ablation. And it's a really fascinating technology, but in folks who have the dysplasia that we discussed earlier, excess mutations in some of the lining of their esophagus, that we have a device that can either go around the scope or even through it that delivers radio frequency waves, radio waves at a very high frequency that essentially burns just the lining of that esophagus tube. It doesn't go deeper than that. And when that heals, it essentially heals back as normal esophagus and it eradicates the Barretts. It takes care of the Barretts. And then there's one called cryotherapy in which essentially a cold substance is sprayed onto that Barrett's esophagus, doing almost the same thing, sort of burning it with cold instead of radio waves, and it will grow back as normal esophagus. So there are a few potential risks to those procedures, but they're fairly minimal. Sometimes people's esophagus can get a little bit more narrow and little difficulty swallowing, but generally fairly safe.
Well, and we know that for those of us who are surgeons, we know that at various times before we had some of these treatments, we would sometimes have to remove the esophagus, particularly if we started to see the changes known as dysplasia that we talked about earlier. So, but we have one other question about Barrett's esophagus, about Carafate, which is a medication that sort of coats the lining of the esophagus. And the question has to do with how safe it is for Barrett's esophagus since it has aluminum. And I'm not familiar with a connection between aluminum and any danger to Barrett's, for someone who may have Barrett's.
I have not heard an association with the aluminum and the Barrett's, but the Carafate we use fairly frequently, primarily for symptoms of heartburn or what we call dyspepsia, symptoms of potentially acid or ulcer problems in the stomach. But
I usually view Carafate as a pretty safe drug because it's not systemically absorbed for the most part and doesn't interact with a lot of other things. And
well, so we're going to move on, or shall we say move down, to the stomach a little bit here. And to get there, we have a question from Cheryl who wants to know, why isn't the small intestine examined as much as the large intestine with colonoscopies? I thought that was interesting because we were talking a little bit about that earlier.
It's a matter of length, part of it. So the EGD, the scope is only so long. They do have double balloon endoscopies, which can get you down a little bit further, and you can get to the small intestines the other direction, but you're only seeing the very end part of that. As I tell people, everybody the gut is divided into 3 parts: the foregut, the midgut, the hindgut. And I can see the hindgut and I can see the foregut, and what's going on in between is a mystery to me because I do not use capsule endoscopy. But if you want to talk more on that.
Yeah, so what is capsule endoscopy?
Well, I was just going to say one other thing too. The good news is that the small intestine is generally pretty well behaved. It doesn't, we don't get cancer and ulcers and things as frequently as we do with the ends of the gut that we can reach with our scopes. So not that it can't develop tumors or things that bleed or obstructions, things like that we need to investigate. But fortunately, it doesn't make sense to do like screening examinations of the small bowel because tumors of the small bowel are so rare that we would rarely pick them up. But I guess on the capsule endoscopy, I'm assuming you have more expertise.
We should describe what that is so
Yeah.
everybody knows.
Right. And I just second what's been said already, that most of the pathology in the intestinal tract occurs in the esophagus, stomach, in the first part of the small intestine or the colon, and very, very little, in fact, happens that's concerning, at least in the small intestine. But if someone, let's say, is having gastrointestinal bleeding, or they have something on a CAT scan that shows maybe some inflammation or something that we're concerned about in that 15 to 20 feet of small intestine, and no one would want a 15-foot scope put in them, so that's another reason, But it's a capsule, it's a large capsule, but easily swallowed, that has a camera built into it, and it takes about 4 to 6 pictures every second with a flash. The patient swallows the capsule, they wear a recorder belt, and it has about a 13-hour battery life. And that capsule just goes through that small intestine, taking pictures the whole way through. And when the battery runs out, the patient brings the recorder back. You don't have to collect the capsule. You can flush that. And then we download it in the computer, and I sit down at my computer with a bowl of popcorn, and I watch it go through. And we determine
Intestine TV.
Right, right. So that's one way to determine if there's pathology in the small intestine.
That's really good.
Yeah.
Well, so now we're going to move back up to the stomach. So I told us we were going to talk about the stomach a little bit. And Ruth from Cloquet would like to know that if somebody has stomach polyps, is somebody more prone to stomach cancer?
I think not. I mean, common polyps that we find in the stomach are called fundic gland polyps. And as far as I am aware, I don't think they're a precursor to stomach cancer like colon polyps are. That's a little bit different breed of cat.
Okay.
I think just like with the colon, depending on what kind of polyp, PPIs can predispose you for those fundic gland polyps, which have no malignant potential. But I have taken out some adenomas out of the stomach, and those do need to be monitored.
Okay.
Yeah. I'd agree. The most common polyp in the stomach is the fundic gland polyp, which is completely and utterly benign. There are occasionally, but rarely, adenoma polyps, which over time can grow and mutate into a stomach cancer, but that's very rare. And hyperplastic polyps is another category of polyps that in the colon are completely benign. In the stomach, maybe have some potential, but in general, stomach polyps, especially the most common ones, are not terribly concerning.
Okay. So thinking a little bit about how contents move through the stomach, we have a question asking about, is Reglan safe for gastric motility to help move the contents out of the stomach?
Generally, all medications have side effects.
Yes, they do.
And so people can have neurologic side effects and things from Reglan, and I believe there's some cardiac, like EKG changes one can get with it on rare occasions. As a general rule, it's pretty safe. And the flip side of the coin is if you have a stomach that isn't emptying properly and you are having trouble digesting things, and that causes your stomach to empty, we always kind of weigh the risks and the benefits. And if the benefit to you outweighs the risk, then it's worth taking the medication.
Fair enough. Well, we have a question from Mountain Iron wanting to know what causes a watermelon stomach.
So watermelon stomach, another name for that is gastric antral vascular ectasia.
I think I like watermelon stomach easier.
I do too.
Okay.
And it's a really pretty picture, but essentially these are capillaries what we also call arteriovenous malformations that essentially come up to the surface of the stomach and can slowly bleed over time, typically not a massive life-threatening bleed or anything like this, but we actually don't really know what causes that. And I've recently done literature searches on this to try to understand it a little bit better, but there are certainly risk factors. Folks who have cirrhosis of the liver, folks who have chronic kidney disease or severe heart disease can get, and it's probably a hormonal and possibly a pressure-related problem, but and there are also some good treatments, that frequency ablation, and also you can use something called argon plasma beam to treat these capillaries. But the short answer is we don't really know what causes it, but it tends to happen more frequently in the folks that I mentioned.
Okay. All right, team, we have an important question coming from Hibbing. And it's one that I think we've often gotten, and it's one that I think a lot of people are curious about. So what causes gas and poop to stink? And of course, it starts all the way up top and has to work its way through. So what causes the stink?
It's going to be a byproduct of the digestion, especially with the bacteria that's in there, and they break down the food. And part of that breaking down process, it's going to release gas, sulfur to be one of them.
Yeah, it just sort of moves through. It kind of starts, it doesn't quite get all the way digested in a way in the stomach, right? And because digestion begins there, but it certainly doesn't end there, right? So, all right. Well, let's go on a different topic, and let's just see what this sounds like to the three of you. So Reggie from Duluth says, do you have any suggestions for pain on the right side of the chest after eating? Doesn't say how long after eating. The pain's at the level of kind of the heart, lingers, but the stress test was normal. So what does that make us think about?
Well, the surgeon in me thinks of gallbladder.
I know, I was just going to say.
Anytime you have right-sided pain, whether it's chest or abdominal, and it's after eating, could be, being in the chest, it could be spasm in the esophagus or something like that too. But commonly, I guess the questions to ask if he was in my office would be, how soon after eating does it occur? Are there certain foods that are worse than others? Show me exactly where the pain is. Do you get nausea along with it? Any family history of gallbladder trouble? Oh. And then I guess part of the workup would be get an ultrasound of the gallbladder to see if he has gallstones.
Well, let's talk about that for a moment. Question I've had over the years is when I've taken out gallbladders has been, hey, you're taking my gallbladder out? I thought I just had gallstones. And I think that's confusing for a lot of people. So why do we take the entire gallbladder out?
Well, for one, to take out the gallstone, you would have to make an incision into the gallbladder, and the gallbladder doesn't heal up very well. So you would have worse complications from that. The body does a very good job acclimating to the fact that it doesn't have a gallbladder anymore, because it's nothing more than a storehouse of that bile. So there are other structures in the body that get bigger to allow them to store up more bile so that we have it available to us when we eat those fatty meals. But it's probably because it's a safer, quicker way to take care of the problem.
Fair enough.
And I'm just guessing I'm the oldest one up here.
But not by much.
But back when I was training, they did a lot of work on trying to dissolve gallbladders. That was prior to laparoscopic surgery,
I remember that.
where we could remove it with small incisions. So everyone got a 6-inch incision under their ribs and was in the hospital for 3 days. So they tried medicines that would dissolve it, but they were quite expensive, a lot of side effects, and only effective part of the time. They tried to blast them with shock waves like we do with kidney stones. And as soon as they started taking them out with the laparoscope and people were going home the same day, those machines started gathering dust, because you're still leaving the stone factory in. And part of the reason people get gallstones is that the gallbladder itself is not functioning properly. It's not emptying well, or it's hyper-concentrating the bile. So even if you're successful at getting rid of the stones, they tend to come back over time. So.
Well, we only have a couple of minutes, but since we're on the topic of the gallbladder, I think there's another term that a lot of folks get confused by. It's that biliary dyskinesia, when the gallbladder itself isn't the problem. Or I mean, the gallbladder, the gallbladder is the problem, but there aren't any stones. Anybody want to take a crack at that?
Sure. So dyskinesia just means that it's not moving properly, and majority of the gallbladders we take out are related to gallstones blocking up the outlet to the gallbladder, but there's a smaller percentage of people for whom the gallbladder sort of spasms. Instead of emptying in a nice coordinated fashion and squirting extra bile into the digestive tract after you eat, it just kind of cramps, and it can cause the same sort of pain that you can get with a gallstone. And so there's a test that we do to look for that called a HIDA scan. And so you're injected with a little low dose of a radioactive tracer that's picked up by the bile, and then the gallbladder shows up. And then we give a second injection of the same hormone that's released by your intestine after eating that stimulates the gallbladder to empty, and we calculate how much of that radioactive stuff is in before and after we give that. And if it's a small fraction, that tells us that the gallbladder is not functioning properly. Most people with that kind of a symptom will actually, the symptoms will improve if we take the gallbladder out.
Or if they have reproduction of their symptoms.
Right.
It doesn't have to be necessarily a very low EF. It has to be on the lower side with reproduction.
I often don't tell my patients that when I'm ordering the test, because I don't want them to look for it. Then I ask them about it after.
Sure. Well, you know, we're pretty close to the end here, gentlemen, and I just want to say thanks for all the great questions that we got from our viewers. I'd like to thank our panelists, Dr. Jon Reich, Dr. Stephen Vopat, and Dr. Derek Williams, and our medical student phone volunteers, Jake Krogstad, Chelsea Petrick, and Peyton Schultz. Please join Dr. Ray Christensen next week for a program on stroke and other neurologic problems, when his panelists will be Dr. Victoria Heron, Dr. Vikram Jadhav, and Dr. Paul Sanford. Thank you for watching. Good night.